Hello everyone, welcome back to my channel, The Theoretical Doctor Audio Blogs. Here I will be sharing my experience as an orthopedic house officer in the operating theater. The link to the article of this audio blog is available in the description below if you would prefer to read on it instead. Otherwise, let's begin. Out of these three, ETD, EMOT, and ward on night, this particular shift has always been my favorite, especially if I'm being called as second houseman to OT. I consider it an immense privilege, but also if there's any place I will actually fall asleep on the job, it is sadly also here. The shift of an EMOT HO in the Orthopaedics Posting is from 7 a.m. till 7 p.m. for EMOT AM and 7 p.m. till 7 a.m. for EMOT PM. Allow me to give you a brief run through on what a typical day or night shift of an EMOT HO is like. Right before our shifts at 7 a.m. or 7 p.m., depending on if you are in the morning or night shift, we are expected to introduce ourselves in the on-call group. For example, good morning or good evening, doctors. This is Jewel, EMOT AM or EMOT PM houseman for today. This is then followed by us sending the pictures of the ortho list, the non-ortho list, as well as the ongoing cases. This act is simply a courtesy to let the group of medical officers and surgeons know who is the house officer on standby in the operating theater. Thus, they would know who to contact to know more about the affairs happening within the OT. Next, if there are any ongoing cases, we will take over from the previous house officer on duty unless they volunteer to stay, and we will also leave our phone number to the OT nurses. This is important as there are times when there are no cases being called and most of us tend to leave the OT. This enables the staff nurses to contact us if a patient from the orthopedics department posted under emergency is being called to OT. What happens if a case is being called? First of all, if it is under EMOT, they will call according to the urgency of the cases through a color coding system: red code, yellow code, and green code. Red code cases are prioritized first, followed by yellow code and green code. Next, is there enough nil per oral time or NPO time? This is important for the anesthetic team. Thus, when a case is being called, we are expected to inform the OT call medical officer. Usually, they will inform what needs to be prepared, such as an access to image intensifier, arm board, a tourniquet, or to have certain antibiotics readily available to be given as stat doses. The time taken for the patient to arrive from the ward is sufficient enough to have prepared all of this by then. After the patient has arrived at the airlock, which is the transfer zone, we are required to inform the OT call medical officer again, as well as when the patient is finally being pushed to the operating theater room. When the patient arrives at the airlock, they will be assessed by the anesthetic team. This is to determine the type of anesthesia suited for the patient. In addition to that, the patients will also be briefed on the mode of administration, risk, and complications of the procedures. This is followed by the consent checking by the staff nurses from the OT. In order for the patient to go for operation, a written consent must be readily available, which is signed by the patient, house officer as witness, and a medical officer. It is during this brief interchange period where I would screen through the case note of the patient for any antibiotics and request the ward nurses to send should there be none provided for the patient. These sometimes do occur and saves the hassle of calling the ward and waiting at the last minute when the patient has already been pushed to OT. After the patient has been assessed by the OT staff nurses and the anesthetic team, they will be pushed to the OT room where they will be placed under the suitable anesthetic block. As a house officer, we are required to ensure the whiteboard in the OT room is filled. Details to be included are date, patient's name, purpose of, location of op, team, surgeon, assistant, circulating nurse, scrub nurse, anesthetic team, and any special instructions. It is best to refer directly to the consent paper to avoid any mistakes, as this board will be used as a reference by the nurses to fill the SSSL form, which which is a short documentation of the pre-op diagnosis, post-op diagnosis, intra-op implants used, samples taken, doctors and team involved, as well as the starting time and ending time of the operation. It is also during this time that we would dilute and prepare the antibiotics. The commonly diluted antibiotics used are cefuroxime, cefazolin, and unacin. The diluted antibiotics prepared are then labeled on the syringes prepared and passed to the anesthetic team to be served intra-op as stat doses or during the following dosage of the antibiotics. Since it is the orthopedics department, it is always best to display the x-ray of the patient on the monitor or television provided for the surgeon to review while the patient is being prepped by the anesthetic team or for them to refer intra-op. After the anesthetic team is done with their administration of the suitable anesthetic block for the patient, it is time for us to help set the patient by positioning the patient and exposing the limb for operation. Then comes the fun part, which is scrubbing in. After we have scrubbed in, the OT called medical officer will usually set the patient by painting the limb or site for op as well as donning the sterile green towels, and after the patient has been prepped, it is time for timeout. What is timeout? It is basically reading aloud every information written on the whiteboard prepared earlier. Only then, we cut. As a house officer, we are merely the surgeon's assistant, such as helping to expose certain areas by holding the retractor, holding the suction, dabbing, and cutting. There are a few instances where we will be given the opportunity to help curate the wound or close up the wound by suturing or even drilling. However, being up close and seeing the procedures alone, as I mentioned, is an immense privilege in itself. Perhaps it is due to the reason that I enjoy hands-on procedures. Pardon my analogy, but in a way it is like cooking, assembling, or fixing furnitures. I feel somewhat at peace and at home in the operating theater. Every procedure duration varies, and after the completion of the procedure, we are required to help draft out the intra-op findings, samples taken if any, implants if any, as well as the further management plan of the patient. This will then be counter-checked by the surgeon before we upload the finalized data onto the hospital's database, which keeps a record of the patient's operative procedures conducted. This is followed by filling in the patient's details and operation done in the green logbook, filling up necessary implant forms or biochemistry or histopathological forms required if needed, filling the white form given by the OT nurses. We will usually help to indent the medications listed in the plan for the patient, which is just a small duty but helpful for the ward doctors, as this ensures the necessary medications required by the patient will be served in the wards, because this can be missed at times due to the negligence of updating the patient's medication chart, which can only be authorized by doctors. Alerting the house officers in charge in wards upon the completion of op done for the patient as a courtesy for them to be aware that post-operative review needs to be done for the patient, after which the case note, medication charts, and necessary charts will be compiled and left on the nursing counter, and the patient will be transferred out to the observation bay for a few hours before discharging back to ward or transferred out to ICU. The cycle then repeats itself again for the following cases until the shift is over. How do you equip thyself? I have a special file for OT, and inside are implant forms, both internal and external implants, KKM forms, TB forms, gene expert forms. This saves time from scouring around the OT looking for it, and you can prepare it beforehand or immediately after the operation is done. There are times when a sample will be sent for TB workup or gene expert, and I learned the hard way after trying to get help from the wards to send these forms down to the operation theater, as this form requires a specialist chop and signature, and getting a hold of them is usually not easy. Hence, it's better to be prepared and bring this file with you every day, because you never know when you will be called as second houseman to OT. Next, remember the connecting line to the radio department if ever you need an access to an image intensifier, aka portable x-ray. Personally, I would save the radiographer's phone number so it would be easier for me to contact them throughout the day. What to do when there are no cases being called? Yes, that does happen at times, especially when there are ongoing elective cases from other departments or there are other emergency see red coat cases. After all, the main operating theater is being shared by all surgical-based departments. Then, there are instances where there are no ortho cases at all, which is quite rare, but sometimes all the procedures would have been completed during the day shift, or there are just merely no cases. So what do I do? First of all, you can always leave the OT. That is why it is important to leave your phone number with the OT staff nurses for them to contact you should there be any cases called. Next, you could help out at wards or the emergency department. Or like me, I'd be hiding at one corner reading or writing. Besides that, you could also chill at the pantry and eat or sleep. However, before indulging in relishing in this unexpected free time, it is best to stock the OT with pinkies, restock the POP trolley with the necessary ortho bands, crepe bandages, and plaster of Paris POPs, as well as to identify the tourniquet and location of arm boards. Hence, when there is a case being called, this saves the hassle of scouring the place and wasting time. Personally, EMOT is an enjoyable experience, and I hope that you are able to appreciate observing and assisting up close in the procedures as I did. True, our role is very limited, and most of the time we are just merely assisting and observing. However, be patient and ask a lot of questions. Do inculcate the habit of having an inquisitive nature. Try to make best out of the experience. There is a learning curve in every area. All the best! Thank you for listening to this audio blog. Do stay tuned for more, which will be available every Wednesdays, Thursdays, and Fridays. Remember to click on the subscribe button as well as the bell button so you won't miss out on any upcoming audio blogs.